Welcome to Inside Urgent Care, hosted by Dr. Cassandra Donnelly, the podcast that brings you real stories straight from the front lines of one of the most dynamic spaces in healthcare, urgent care. Whether you're in the field or just curious, this is your go-to spot for honest conversations, insider insights, and the voices of those who make it all happen. We're so glad you're here. Let's dive in.
So welcome back to the Urgent Care Podcast. I am Dr. Cassandra Donnelly, the host of the new podcast.
Thank you again for joining us today, Martha. So happy to have you and to be able to discuss our important topics today. Looking forward to us jumping in and really getting to understand and have a great conversation that we can share with our listeners.
Sounds great. So I'm Martha Williams. I am a physician assistant. I've been a physician assistant for about 15 years. And primarily I've worked in urgent care during that time and some slew in internal medicine, hospitalist medicine, and emergency medicine. So I feel like I've had a great background in kind of evaluation of people in all different settings. And I also work as a clinical content specialist for the Urgent Care Association. So I have a great opportunity to work with organizations like the American College of Obstetricians and Gynecologists, as well as working with the College of Urgent Care Medicine to help act as a liaison for educational purposes.
All right, Dr. White, introduce yourself as well.
All right, my name is Jenna White, and I'm an emergency medicine and EMS physician in Albuquerque, New Mexico. I work in the University of New Mexico Health System, and I'm also the chair of the OB Emergencies Project with ACOG, the American College of OBGYNs. And through that project, we've partnered with the Urgent Care Association to develop educational materials and treatment guidelines for patients who might be experiencing pregnancy-related emergencies who present to an urgent care in order to receive care and treatment. So thank you so much for having me. I'm really excited to have this conversation today.
And thank you also for joining us. I am very excited about this conversation. It's been long in the planning, and I know it's going to really give our listeners something that they can use in their clinical practice. So let's jump right in. But what are some signs and symptoms or even complaints that your patients have when they visit an urgent care? If you can think about something that your patient told you that was the reason why they went to an urgent care, what are the common things that you find that sends a patient to urgent care?
Yeah, so I'll jump in on that first, if that's okay. Certainly in urgent care, we see a ton of respiratory complaints, particularly the shortness of breath, chest pain. And I feel it's really important as an urgent care clinician to risk manage that, really go using algorithms as well as clinical decision making to determine, are these individuals low risk versus moderate risk versus high risk? And is this something as simple as an upper respiratory infection or something more concerning like a possible NSTEMI? And especially when we're dealing with pregnant individuals and postpartum individuals, I think there is a lack of understanding for how to risk those patients in the urgent care setting. So I think that's one of the biggest things that we really need to work on, because it's such a common complaint to come in feeling some of these really worrisome issues that might be a signal for something more significant in these patients.
And I think to follow on to what Martha just described, pregnant and postpartum patients might present to urgent care with many of those same symptoms and certainly could have upper respiratory infections, influenza, etc. The problem is that some of the unique physiology that is inherent to the pregnant and postpartum state can also predispose those patients to some really significant medical conditions that can have tremendous morbidity or even mortality if they are not diagnosed promptly. And so I think therein lies the challenge when treating patients who are pregnant or postpartum, is that they can have very vague and frankly even low acuity sounding complaints that can actually be indicative of something really serious underlying.
That's a really important point. And I think that today that's something that we should really hone in on. The fact that pregnant and postpartum patients can present with vague symptoms. And those vague symptoms can often lead to something much more serious than we anticipated in our non-pregnant, non-postpartum state. And so I'm so happy that you brought that point up. What info would you find most valuable in these patients that come into urgent care, right? From a clinician's post-visit feedback. If you could say to the physician or the clinician, my patient was there and I really want to know X, or I really want to know Y about that patient. What is it that you think you would find most valuable? What would you say to the clinician that at that particular time that they're seeing your patient couldn't get a hold of their OB, right, physician to ask certain questions? If you can think about that and kind of walk our clinicians through the valuable questions. We all know that the history tells us almost everything we need to know about a visit before we even, decide what's going on with them or to examine them, just listening to them. As we've talked about a few times on this particular podcast, listening to them gives us great insight. If you can think about what that post-visit follow-up would be based on those questions you want us to ask, kind of walk us through that.
Yeah. So I know from an urgent care standpoint, when we're taking a history, I do feel like sometimes a lot of us clinicians have this unfortunate time crunch. We are really told throughput time is terribly important. And I think, and I can't speak for everybody, but I do think that it's been an unfortunate issue in terms of how well we're asking these review of symptom questions, and that we're relying a lot on our triage staff in terms of getting that chief complaint and a little bit of the review of system questions. And I've seen clinicians that go in and talk and they make those comments when they're getting ready to work on the assessment and plan. They're like, oh, this person's pregnant. I mean, that's a question you should be able to really know when A, you're even walking into the room if you've reviewed the intake questions, and then just if you hadn't, that when you're asking the patient about it. History, you can't know what you don't ask. Right. And so if you're not asking those questions, you can't really rule out anything that would be something if you just never asked about it. And so, I had a clear patient just the other day that came in very specific symptoms in terms of I felt a little discomfort when I'm breathing. I've noticed that I like especially worse when I'm laying down. And she was really leaning more towards this is definitely respiratory. But I was like, so I see that you've had some kids. I know that. So did you just have a kid? Is this something that you've done within the last year? And so I was able to better risk stratify her because I asked those questions. So I think that is going to be the most important thing is making sure that your history is getting to the root of looking at each patient individually.
Yeah, I would agree with that. And I love that Martha brought up like we can't know what we don't ask, because that I think is actually one of the most important elements of an urgent care visit for a patient who might be pregnant or postpartum is that they are in fact recognized to have been pregnant or postpartum. I think just asking that question really opens the door to thinking about some of these diagnoses that are frankly not going to be on your differential if the patient has not recently been pregnant, right? You're not going to suspect like a peripartum cardiomyopathy in a patient whose last pregnancy was 40 years ago. So, but someone whose last pregnancy was 4 months ago and comes in with cough, fatigue, similar symptoms, that clearly needs to be on the list of possibilities. So I think first and foremost is just that you inquired about current pregnancy or recent pregnancy. And when I say recent, we really are talking about out to 1 year postpartum, which seems like a very long time, especially since many of us often think about the postpartum period as ending around 6 weeks after delivery. But we actually know that the risk for a variety of pregnancy-related illnesses actually extends well beyond that 6-week part, that 6-week mark, and throughout really the first year after the pregnancy ends. So framing that question and asking that piece of information is so crucial, I think, at any unscheduled healthcare encounter in that first year postpartum or during the pregnancy. I would say, secondly, that a thorough recording of vital signs is another just really crucial element of a visit to an urgent care facility for a patient who's pregnant or postpartum. There are certainly vital sign thresholds that are specific to pregnancy and that are frankly different than in the non-pregnant individual. And so obtaining vital signs and conveying an awareness of the fact that our thresholds for normalcy are different in pregnancy, and that you appreciate that as a clinician. And if that patient's vital signs were outside of that range that's considered normal, that you recognize that and took the next steps to connect that patient to additional resources, additional workup, et cetera.
Yes, that's a very good point that you mentioned here in regards to vital signs. I think that most of us generally remind our colleagues that are helping us in the centers, usually a medical assistant or in some cases a nurse, that vital signs are vital. These signs are not relative signs. They're not signs that we should not focus on. We should be very focused on vital signs because they're put there to tell us something. In the abnormal state, these are usually waving at us on our board with a red flashing sign or a red exclamation point next to them. And even in the ones that are at the higher end of normal, we should be just as concerned about these because we're likely seeing someone that is about to cross over into the threshold of being abnormal. And therefore, that's a patient that is in a state that is about to change from normal to abnormal. And they're really the ones that we should be focused on. These patients are very important to recognize because we have them right in front of us. And those are the ones that we can have an impact on. And for the postpartum patient or the pregnant patient whose heart rate or blood pressure are right at the edge of high normals, these are the ones that we want to make sure that we investigate further. We have an opportunity to be able to be proactive in what happens with the disposition of these patients, and we should recognize that. I think it's going to be a great take-home point in this conversation to have this thorough evaluation of the vital signs and then the recognition of those watershed, I'll call them, areas of abnormal versus just highly at the high end of normal. Now, Martha mentioned the evaluation of a patient and asking these particular questions at any unscheduled visit up until the 1 year mark. Are we suggesting that we also should conduct pregnancy tests on these patients of childbearing ages, let's say from age 10 to 60, at every visit that we see these women in the urgent care, regardless of their chief complaint? How do we best advise our clinicians about this? And likewise, the patients that are postpartum, let's say 1 year, by making sure that we're asking those patients of childbearing age if they've had a baby in the preceding year. And that means asking every patient of childbearing age this question.
I wouldn't say that I'm in the habit of routinely checking urine pregnancy tests on every single patient who's capable of pregnancy necessarily. I think if someone comes in with, say, a laceration or something that is fairly straightforward and unlikely to be related to a potential or recent pregnancy, then I'm generally not reflexively checking a urine pregnancy test. I am, however, in the habit of asking every pregnancy-capable person about current or recent pregnancy. And that is really to continue to train myself to make that part of my social history gathering. Um, there are many patients for whom coming in and providing a urine sample could be a barrier to receiving care for something that I think is otherwise unrelated. So I do try to just make it a habit to ask so that I am doing things the same way every time. But I wouldn't say that I'm always checking a urine pregnancy test. If the patient has any infectious symptoms, if they have any constitutional symptoms, any neurologic symptoms, any cardiorespiratory symptoms that I'm working up beyond just a conversation with the patient, then I would say, yes, I am checking a pregnancy test in those individuals.
To hop in on that, I think it's very important to have conversations with your patient. We're not the paternalistic clinicians that we all are probably originally trained under. Shared decision making is so important. So I'm just like Dr. White. I ask everybody that's kind of within that, even like my 10-year-olds, I do ask. And they always joke and laugh. And it's like, it is a serious question. Just ask me, answer it really quick. But I ask all of my childbearing age individuals of that. And if it is something that they're really hesitant to test, like say they're exactly 30 days from their last menstrual period, if they don't want to do that, I do document in the chart that we discussed risks and that they, wanted to test at home. So it's important, right? You need to ask, but you also need to respect the patient's wishes, but ensure that you do discuss with them potential possibilities if that is a positive test.
Sounds good. All right. So my next question is, what are the specific questions that would alter your disposition from home to emergency department to specialist for this particular patient scenario that I'm going to give you? I recently took care of a 36-year-old female who presented to the urgent care with a chief complaint of facial swelling. She noted that 3 days ago, she was on her usual walk around the track in her neighborhood, and she started to have some facial swelling and chest discomfort. She refused and denied chest pain, but it was uncomfortable enough, and really, she eventually stated that it was a shortness of breath that caused her to end her walk sooner than she would have. She said that this wasn't the first time she had to cut her walk short. However, it was the first time that she had to end it that soon. And so this had become progressively worse over what she described as the preceding 6 weeks. And so she presented to the urgent care with facial swelling and a mildly elevated blood pressure. During the course of her workup, she began to divulge that the very first time she noticed the shortness of breath was actually a few months ago. And it had been about 45 minutes into her visit, and her vital signs at this time were fairly normal. Her heart rate and blood pressure, as I recall, were normal. Well, her blood pressure was 142 over 88, so certainly her slightly abnormal. And she denied having a history of high blood pressure. The highest she remembered during her pregnancy was a systolic of 142. And so this is her first time having a blood pressure this high. I began to ask her about when the first time was she felt the shortness of breath, and this was as she was going around the track. She first noticed it 3 months ago. And I said, well, what happened 3 months ago? Well, 3 months ago, I had just been released from my OB to begin exercise. And this was my aha moment. It was aha because I now realize that she had recently had a baby 3.5 months ago. And I said, okay. So now, of course, I'm getting very interested in this patient that has facial swelling because she's mildly hypertensive, again, at only 142/88, which is for the average person, likely not much to write home about. But for this particular patient, she now becomes very important to us. And I'm very concerned, jumping up and down in my mind about what I believe I have on my hands. All right, so she tries to walk around the track. She can't because she's too short of breath. And in the immediate, not so immediate, recent, I'm learning that she has had a baby. She's postpartum. And because I'm looking now in the first year postpartum, um, I'm very concerned. On her medical record, when I dig in a little further, I noticed that she had indeed followed up with all of her visits, but in talking to her, I understood that she had not divulged this particular complaint to her obstetrician on any of the visits that she had had since having this baby. But as I began to pull the history from her more and more, I learned that this is a different patient than I thought that she was. And it was only because I asked her, when did you first notice the shortness of breath? So again, as you think about this particular case, what I thought was pretty interesting was all of these constellation of symptoms and signs that I was able to put together by just digging a little bit more into her past. And so this is, of course, my first visit with her as in the urgent care. What makes our patients a little bit more complicated is that we usually see people one time for one thing and not again. And so it makes our visits moderately complex just to start. And so I asked this woman now with facial swelling, I'm trying to appreciate how much swelling there is. And I asked the husband for a picture of her. And they had a picture of her when the facial swelling started. And of course, I can see her today, but the amount of puffiness in her face was pronounced. She had a full face, and previously her face was quite thin, and so it was really remarkable about how different she looked from only 2 weeks of symptoms. All right, so what's my question? My question to you all would be, in the disposition of this patient from home to the emergency department, what are we looking for, right? What's the workup? What are you advising me as the clinician to do in this particular scenario?
So I certainly from an urgent care standpoint, there's several red flags, right? You have progression of symptoms. If this was an isolated incident, maybe we could talk about kind of a low to moderate risk, but progression of symptoms and now truly inhibitory for daily activities, that's going to be a huge red flag. Taking away the objective findings that you had, that's still something that is making my spidey senses tingle. And so then when you add on some of those objective findings, mildly elevated blood pressure, uh, it's now you're increasing that risk factor. And so I'm already considering this is not good. She is not in the right place. And so then we start talking, do we want to do further workup in our facility? You could consider doing a chest x-ray, or are you delaying her getting to appropriate care? Because this lady is going to need further workup. Imaging is definitely going to be considered with a chest x-ray at the ER probably first, but she's going to need some labs and really assess where she's at, especially now that you start bringing in some of these other findings that you might not have appreciated initially with the facial swelling. And so, yes, the blood pressure is kind of but you have everything else. Then you add on the history when you're even getting more information. She's definitely not supposed to be in the urgent care. She needs a little bit more higher level of care. And when you're doing that handoff, it's going to be so vital that you're describing that this is a progression, that this is a distinct facial swelling, because it might, no offense to Dr. White and her colleagues, might be written off as, that blood pressure is nothing to worry about. So I think that's also going to be very important from the urgent care standpoint.
Yeah, absolutely, Martha. I love that you used the term red flags because that's exactly how we describe several of this patient's symptoms in the algorithm that ACOG jointly developed with the Urgent Care College of Physicians and the College of Urgent Care Medicine for the evaluation of cardiovascular disease in pregnancy and postpartum. And there's actually a red box on the algorithm that says red flags for cardiovascular disease in patients who are pregnant or have been pregnant within the last 12 months. And this patient actually met several of those criteria: chest discomfort, slightly elevated blood pressure, elevated respiratory rate, change in exercise tolerance, edema. So there are a lot of things in this patient's story that I think are concerning, especially given her postpartum state. And this is definitely a patient that I would want to see have a more exhaustive workup. And I think that transition of care that Martha alluded to is so critical. I think acknowledging like the progression of symptoms like Martha described, but also making crystal clear, even if you have to say it 5 times or write it in red marker across the top of your transfer paperwork, like patient is 4 months postpartum, because that is really the clincher, I think, in this case, is that if this patient were not within a year postpartum, it saves her life.
I couldn't agree more. And that connectivity and that transfer or handoff to the emergency department, that information is going to be vital once it's provided. As an ER physician, that particular information of the what, the who, the how, the what's been going on makes the visit go one way or the other. And as we know, well, most of us know that once you have a diagnosis on someone from the emergency department, or even in your mind, you're thinking of a diagnosis, once it goes on paper, no one changes that diagnosis unless something drastic happens after admission. So for me, connecting with the triage nurse at the emergency department and honing in on the fact that this woman had a baby 4 months ago and she has X, Y, and Z symptoms, for me, this made all the difference in the world because the receiving team was happy. They were ecstatic that now they could have someone that they could investigate, someone that they could potentially do something about. But if you or I send her out from the emergency department, let's say to home, and just say, all right, go on to the emergency department when you have time, and let them know that your blood pressure is a little bit elevated and that your face has been swelling, we know that there's a great potential for her becoming very frustrated from long ED waits, and leaving is a very likely scenario without being seen, and this patient would just wait around to her next OB appointment. And unfortunately, bad things happen when patients present over and over again to the same complaint and nothing is done to progress them into the right direction. And so I was grateful to be able, and so I was grateful to be able to have the ability to intercept her care, because I think the other thing that we all know as clinicians is that we can at times be blindsided by how many times someone presents to the health facility dealing with a particular condition, symptom, or diagnosis. And we can put that person off and think that it's not a urgent or emergent condition because it's been going on for an extended amount of time. It can be pretty chronic, 3 months. I may be able to allow her to follow up with her OB or to have her see her primary care for the next visit. However, as we are finding out in the postpartum patient, that is not the way to handle her disposition. And the other thing is that because this new mom has chosen to put off her care, it doesn't mean that this is not something that's important or that should be handled emergently. It means that she's been able to cope and to compensate while she's been doing other things like taking care of a brand new baby. But this is her defining moment. This is her time zero. And it's a great time that we have to intervene in her care because 9 times out of 10, it won't come again. All right, so my next question. Based on all of the information shared today, what are some things clinicians can start implementing in their practices tomorrow? I know the one thing that we talked about has been the recognition that this is a 1 year postpartum period in women that have had children. It's not the 3 months that we have likely been taught or that we've thought about or in the past, and it's certainly not 6 weeks, but it's 1 year postpartum. That's a time frame that we should have in our minds. This woman can be affected by all of those things pregnancy related. And so, what are those things that you want to know? What are those things that you want folks to start implementing tomorrow in their practices?
I think from the urgent care standpoint, there are kind of three things I think is going to be very vital for your patients. One is just like, hey, when was your last menstrual period? It definitely should be. If you've been pregnant, let us know if you've been pregnant within the last 12 months. And ACOG's developed these nice little room signs that so you don't even have to do anything except print it off and slap it up on the wall, just like what we do with radiology, right? Inform your technician if you think you could be pregnant. I think that is just something that is easy. It doesn't cost anything, and it can save everybody, right? So I think that's a great option. The other thing is that education for clinicians, if clinicians are not aware that slightly elevated blood pressures in the normal population are red flags in pregnant and postpartum patients, then again, if they don't have that knowledge base, then we're not going to be able to treat them or appropriately risk stratify. And again, it's free. You can send out those emails, acknowledge that people have read that. I mean, just a simple thing. If you want to do something fancier, like a little webinar for your group, great. But, it's a very easy way to send out that information. And then third, which I think is going to be very helpful, is the algorithms that Dr. White had described earlier that ACOG and UCA worked with to develop. Um, we all like algorithms, we all like guidelines, right? And so, like for example, if you have a chest pain patient, you're going to use the heart score or the, HEAR score if you're stratifying somebody. And especially in that handoff to emergency departments, you can document that really easily on a transfer. And ER physicians may not have been notified of these algorithms yet. So I print them off and I highlight my concerns when I'm sending it with the transfer paper. So these algorithms, if you can review them, look at the guidelines, it is going to be helpful in terms of stratifying your patients. And those are things you can implement absolutely tomorrow.
Yeah, I would echo what Martha described about just trying to detect these patients in your center. So asking about current or recent pregnancy out to 1 year postpartum, because again, that's just such a crucial piece of information to connecting the dots in your mind to potentially pregnancy associated pathology. So that would be sort of my top recommendation. If I only had one, I think if I could have two more, one would be to, again, just have a little bit of familiarity regarding some of the vital sign specifications in pregnancy. Again, we're looking at systolics of 140 and greater and diastolics of 90 or greater as potentially problematic in the pregnant patient or someone who's within 6 weeks postpartum. You get a little bit of leeway with heart rate in pregnancy. Really, if your patient has a heart rate in like the 110s, 110s, that's potentially within the range of normal expected in pregnancy. But you also take a little bit of a hit on your oxygen saturation when you're pregnant. So we expect pregnant patients with normal lung physiology who are healthy to have saturations above 94%. So again, training yourself to have a little bit more sensitivity of recognizing potential hypoxia in a pregnant patient. We might tolerate a saturation of 92 in an otherwise healthy adult. That could be indicative of a problem in a pregnant patient. So those are kind of two vital sign specifics that I think are important to be able to recognize in pregnant patients in particular, and those that are newly postpartum. And thirdly, again, just can't emphasize enough referencing the algorithms that ACOG jointly developed with UCA and the College of Urgent Care Medicine. They're on the ACOG OB Emergencies website, which is acog.org/OB Emergencies. And there's a section for urgent care. So you can download them, you can put them on your phone, you can save them to your facility's desktop or intranet, whatever kind of file sharing capability you might have. You can print them out and post them. And they're great resources to be able to reference if you think you might be treating a patient that potentially is having signs and symptoms that are concerning for cardiovascular disease, if you have that patient that has elevated blood pressure, or if you have someone who's having bleeding during pregnancy or afterwards. They're great resources because, again, really nobody outside of kind of the obstetric world takes care of these patients all the time. So it's so great to have a reference that you can go to in the moment, and it will tell you essentially exactly what to do.
Yes, thank you for that. It's an important point. I know that our clinicians that are listening appreciate this additional insight coming directly from this group about such a special population. These types of conversations usually bring back to my mind patients that I've seen in recent months or over the past year that I consider near misses. These are the ones that I learned from and we learned from. Before something goes catastrophically wrong, we think about what we could have missed in that patient. They allow us to make certain and make sure we don't miss them in the future as we move forward. We think about those clinical questions that need to be asked of a group of patients of childbearing age. And this now goes beyond the menstrual period. It must include, have you been pregnant within the last year? This now becomes standard in the HPI. We cannot forget rather to ask this question. We got to ensure that our clinicians are very comfortable also with the pediatric patient that has a gynecological concern. The 10, 11, 12-year-olds that need to be included as we review sexual history and, of course, the menstrual history. It's our responsibility to educate this young group of patients. We got to make them equally comfortable with sharing their gynecological history with us in a caring and non-judgmental way. And I just think this cannot be overstated. It's a very important point, and I want to thank you, Martha, for bringing it forth. All right. Well, this brings us to the end of our questions. Is there anything else that you all had hoped to convey during this discussion? This is kind of an open mic that you can talk about something that you want to talk about, anything from soup to nuts.
The one thing that I would say that's very important, kind of from an urgent care standpoint, do not delay appropriate care to do further testing in your facility, right? Like if you have a high suspicion, get them to an appropriate ED facility that has OB care, because if you are delaying that care, you're delaying getting that proper fix, right? So don't delay care to further evaluate. If that risk is there, get them on to the appropriate place.
Yeah, the one thing that I want to make sure that our clinicians hear also is that, the one 3-second test that everyone should recognize that we need to do in urgent care is that critical EKG, right? If that person comes in with chest pain, shortness of breath, chest tightness, something, chest anything, and you're considering sending them out, make sure that you're not sending that person out with a very identifiable, as you mentioned before, a very identifiable STEMI, something that a person in AFib, new AFib, right, with rapid ventricular response, just something that we can identify that fast while EMS is on the way, right? We should be able to do that and hand off that particular part to our ED colleagues very well.
I would also say too, for anyone that's curious, the genesis of the OB Emergencies project with ACOG and our partner organizations was really a recognition within state maternal mortality review committees that there were pregnant and postpartum patients who were seeking care in emergency departments, who were going to urgent care facilities, who were calling 911 and being cared for by EMS personnel, who had these encounters with this group of unscheduled care providers, and then unfortunately went on to have a bad outcome and who actually experienced some sort of fatal complication. And those deaths were captured through maternal mortality review committee reviews across many states. And there was a conglomerate of recommendations that all kind of centered on this idea of needing to improve our recognition of these patients who were potentially at risk for conditions like this in these types of settings, EMS, urgent care, and ED. And that was really the impetus for initiating the ACOG OB Emergencies program. And that's the direction we've been moving in for the last several years, is to work together as urgent care, ED, EMS clinicians with ACOG to develop resources to help all of us do better at recognizing and taking care of this patient population so that we can potentially prevent maternal deaths that are preventable. And so I guess this would be, I would encourage urgent care clinicians to rely on these resources, to get in the habit of asking about current or recent pregnancy, and also to feel empowered that you may be the person who recognizes this constellation of symptoms in this particular patient and actually save a life.
Thank you so much.
Amazing. Absolutely. Couldn't have said it better myself. Thank you so, so much. I really appreciate the time that you've taken to educate our clinicians and to share the wealth of knowledge that you have. It's a field and a subset of patients that are so vital to our healthcare community. And the care of these patients, I think, cannot be overstated. We need to make sure that we're doing the right thing by our pregnant and our postpartum patients. We need to recognize that we live in a country where our mortality, maternal mortality, is at a higher rate than the average first world country. And as clinicians, it's up to us to be mindful that we stay educated about those things that affect these patients so that we can intervene for the betterment of them. So thank you so, so much.
Thank you so much for the discussion. This was great.
Yes, thank you. This is exciting material for us all to share in the urgent care setting as well.
And so this has been Cassandra Donnelly hosting the Urgent Care Podcast and bringing you the best of what urgent care has to offer. Thank you so much, and I hope you tune in next time.